Good evening, everybody, and welcome to this evening's Facebook Live session. My name's Sam Chakosky, and I'm the Sales Manager for Wound Care People. I'd just like to start by thanking you all for joining us this evening. We do really appreciate you joining us. I'm also just going to remind you that we are all broadcasting from our homes, so in case there are any technical issues, I'm sure there won't be, but in case there are, please do bear with us. Tonight's session is titled Optimising the Space Where Wound Healing Takes Place, and we're joined this evening by two very special speakers. We've got the wonderful Joy Tickle, who's the tissue viability nurse specialist from Shropshire. Hi, Joy.
Hi Sam.
And we've got the equally wonderful John Timmons, who's the International Medical Director for Mölnlycke. Hi, John. How are you?
Hi, good. Thanks, Sam. Hi,
yeah,
Joy.
Looking forward to this evening. I've done many Facebook Lives, but I've always been behind the scenes, commenting and sharing things. So it's my first time on camera, so I'm looking forward to it.
You'll be fine, Sam.
Cheers, Joy. I think actually, Joy, you were on the first ever Facebook Live, so.
I was. It seems a long time ago now, but yeah, but I love watching them as well. As well as participating, I love watching them.
Well, it's good to be here anyway. So I'm just going to go through a couple of bits of housekeeping very quickly before we get started. Firstly, the certificate link will be available at the end of the presentation. We'll post a link in the comments section and it will be on the slides at the end. Also, throughout the presentation, please do send in any questions that you have for John or for Joy. We'll get through as many of those as possible at the end of the session as well in the live Q&A. Finally, before we get going, just a big thank you to Mölnlycke for supporting this event. We wouldn't be able to put on this event without their support, so a big thank you to them as well. So without further ado, I will pass you over to Joy to begin tonight's presentation, and I will see you at the end for the live Q&A. Thanks very much.
Thank you, Sam. Just a sign of age now, so the glasses have to go on. But welcome, everybody. Thank you for taking this time, precious time, I'm sure, to join us this evening, and to hopefully, by the end of this presentation, John and I will have achieved supporting you in your clinical practice with education. I'm going to be addressing, alongside John this evening, is looking at complex clinical challenges in wound care. And part of the objectives of this evening is we'll look at many clinical challenges, exudate management or poor exudate management being one of them, but also addressing why exudate is important and its impact on wound healing. But then we're equally going to look at the impact of poor exudate management for the patient, for you as a clinician, and for the healthcare provider, importantly. We're going to address other clinical complex challenges, such as managing that fluffy, devitalised tissue. John's going to be talking to you about reducing microorganisms and biofilm formation, a real key point in today's wound care arena. And we're going to talk at length about the 24-hour window, and also what I call the window of opportunity, when we can implement an accurate assessment and wound management in a timely manner. It's that window of opportunity. And hopefully at the end of tonight's presentation, we'll share with you some solutions for effective management of your wound exudate and other associated clinical challenges as well. So let's begin with one of those clinical challenges, high exudate levels. We often associate in practice exudate negatively. We see the negative impact, or remember the negative impact of wound exudate. But let's take that back a step. Let's remember that exudate is a natural liquid produced from all wounds. It's derived from interstitial fluid found in spaces between the cells. And exudate is vital. It is vital for the wound healing process. Without exudate, wounds would not heal. It's produced mostly during the inflammatory phase of wound healing and the proliferatory stage of wound healing. Now, you might say as a clinician, why is that important that I know that? It's so you are prepared for that increase in exudate during those phases of wound healing, and you're prepared to manage that. And as I've said, it's essential for the normal wound healing process. And exudate is good. You know, like I say, we talk about the negative aspects, but actually exudate is essential. Exudate allows the diffusion of vital healing factors, diffusion of those healing factors through the migration the tissue repairing cells across the wound surface. So without that fluid, those new repairing cells and also repairing cells for angiogenesis would not be able to migrate across that wound bed. It wouldn't be able to undertake its function. So that migration also promotes the cell proliferation and delivers essential nutrients such as proteins and carbohydrates and water required for that cell metabolism. In turn, that provides that moist wound environment. And we know following Winter's work back in the 1960s, how important it is to maintain a moist wound environment to encourage that moist wound healing. We don't want a dry wound. We don't want a saturated wound. We need that moisture balance within the wound. And finally, what EXUDATE helps to facilitate is the patient's own body to assist with natural autolysis. And by that, we mean the natural breakdown of any devitalized tissue, the destruction or hindrance of the proliferation of microorganisms. It helps to facilitate that breakdown of sloughy, devitalized tissue on the wound bed. So as I say, it's essential. And EXUDATE volume, as I've said, will vary. It'll vary at different stages of the wound healing continuum, and it will vary between different wound etiologies. For example, wounds developed from burns may produce more EXUDATE. Wounds located on the lower limbs due to maybe dependency, edema, or gravity may produce more EXUDATE. And of course, the larger the wound, the deeper the wound, the more EXUDATE will be produced. So as a clinician, when assessing your patient's wound, you're assessing not only the etiology, but you're looking at the location, the depth and the size, all which will help you to ascertain how much EXUDATE may be produced from that wound itself. But as you can see from the slide on your screen, if high volumes of EXUDATE are mismanaged, it can lead to negative consequences and increased clinical complex consequences to your patient. What happens, that increased amount of EXUDATE will also contain waste products. It will also contain high levels of proteases and enzymes, which left in contact with the wound bed for too long a period or with the surrounding skin, as you can see in this patient's wound, will lead to significant skin damage. It will erode the skin or the wound bed and cause significant damage. We then can see that increased level of, but we will have an increased level of microorganisms, increased risk of infection. Local infection, spreading infection, if worse, sepsis. Those higher levels of inflammatory factors, as I said, will mean the wound will become stuck, as I like to call it, or stagnant in that inflammatory phase, delaying the wound healing even further. We may get damage, as you can see, of maceration, that waterlogging effect of the EXUDATE sitting within the cells and the skin itself, or maceration from the erosion of the waste products. We have, as well as reduction in new cell proliferation, reduction in growth factors, which, as I said, overall means delayed wound healing. For me, the consequences are dire for the patients. You can imagine the negative impact on the patient's quality of life when managing, when EXUDATE levels are not managed effectively. So as well as EXUDATE being a clinical complex challenge, so are biofilms. And I'm going to hand over to John now. John's going to talk to you briefly around the 24-hour window to prevent that biofilm formation. Thank you, John.
Thanks, Joy. Joy's talking about delayed healing due to the mismanagement of EXUDATE. What I want to remind you all as well is that sometimes biofilm, which forms on the surface of the wound, can also contribute to an increase in EXUDATE volume, but also to delayed healing. And whenever people ask about how do you diagnose a biofilm, one of the key things for me is actually that stasis that you get when the biofilm has covered the wound and it's kind of taken over. So what is a biofilm? Let's go back and have a look at what a biofilm actually means, what it is. And essentially when bacteria adhere onto the surface of the wound, they not only multiply, but they also start to communicate, and they communicate through what we call quorum sensing. And quorum sensing is when they detect other bacteria, even of different types in the wound. And when they get to a certain stage, they start to develop an extracellular matrix, if you like, and it's tend to be a kind of sticky, glycosylated matrix. It's very sticky and it's very protective for the bacteria themselves. So what that means is the bacteria can live happily under the biofilm, and it protects them from antimicrobial activity, which is quite an important thing. We'll come back to that in a second. So what we think about is, when we think about a biofilm bacteria, we think about one that is almost dormant on the surface of the wound, but there's enough biofilm to prevent wound healing. It kind of gets in the way of the normal wound healing processes. It uses up the nutrients that are there. And of course, it doesn't look like an infection. Joy mentioned some of the issues there with wound infection, but actually a biofilm doesn't really present as an infection. And to find is that a biofilm will just be, the wound will be static, and it might change colour, and I'll show you a couple of wounds later on where that's the case. But actually, we're all experts at managing biofilms every morning and every night because we manage the biofilm that is plaque on our teeth. So every morning we get up, and if you run your tongue around your teeth, you'll know they feel very rough. And of course, there's a sticky substance there. And overnight, what's happening is bacteria are forming biofilm, which is obviously plaque on the surface of your teeth. And the best way to get rid of that, of course, is what do? We use an antiseptic, we cleanse, and we need a toothbrush. We need to actually get in there and physically disrupt the biofilm. And of course, you all know how it feels when you've cleaned your teeth in the morning. They do feel smooth, you've got rid of that. And of course, what happens over the course of the day is that the biofilm can reform. And okay, so we'd never use just a mouthwash. You've got to use something to physically disrupt the biofilm as well. So the same thing goes in wound care. You have to use cleansing agents, and sometimes we might use normal saline, other times we might use a cleansing solution, such as, say, a hypochlorous solution or something. And then we have to physically disrupt. So we might use one of the methods of debridement. Autolytic debridement is something that we use commonly, but we might actually use sharp debridement when it comes to managing the wound. We might use a debridement pad. But either way, the best thing to do to try and get rid of biofilm is to physically disrupt it. It's kind of like waking up the cells, get rid of that extracellular matrix, and then you can start to use topical antimicrobials. Then they're much more active in the biofilm itself. And when Joy talked about the 24-hour window, that's what she's referring to. When you've disrupted the biofilm, you want to prevent the reformation of it, and that's where your antimicrobials come in. And really importantly, and as Joy's been mentioning throughout her presentation, the issue of reassessment is important. You know, sometimes I know that you as nurses have not a huge amount of time to manage patients with wounds. But the key thing, of course, and we all know this, is that when you go to see a patient and you take the dressing off, it's about reassessing what's happening there. Have you got rid of the biofilm? Is the wound moving forward? Is it progressing? Or is it still static? Do you need to challenge that wound with something else? Do you need to add something into your care regime? In terms of debridement, there's been a lot of a sort of mystique around debridement over the years, but actually there's lots of things that nurses can use to debride wounds these days. We can use debridement pads to help shift necrotic and sloughy tissue. If you look at this wound here, this is a patient with a diabetic foot lesion. I know it looks like a pressure ulcer, but what we're seeing here is a diabetic patient. And essentially what's happening here is we've got a breakdown of the tissue, and we've got a lot of necrotic tissue in there. And that wound, you can see by the colour, by the rolled in edges, that wound is static, it's not moving forward. So what we need here is to challenge that wound by debridement, and also by using an antimicrobial to take that wound on to the next phase of healing. And and the other thing to remember with debridement is that it's an ongoing process. You won't get rid of all the sloughy tissue, and you won't get rid of all the biofilm the first time you actually manage it. You've got to keep going, and every time you do a dressing change, you have to keep debriding. And of course, with these patients, once you've stopped debriding, then you have to start using something that will help keep that wound moist so that you can soften the sloughy tissue that's there. And of course, we mentioned earlier that you've got a 24-hour window after debridement to prevent reformation of biofilm. At this point, you should be using an antimicrobial topically to help to manage that wound in between dressing changes. So that's really important. So as I said, we've got this 24-hour window, and if you look at this patient here, it's again another patient with a diabetic foot lesion who had at one point a streptococcal infection, but after we got rid of the strep, then we had to still maintain this patient with topical antimicrobials because they had a biofilm. And if you look at this sloughy tissue on the left here, that is preventing healing. We need to get rid of the slough, but also within that sloughy tissue is likely to be biofilm. And once you get rid of that sloughy tissue, it's much more easy to actually try and heal the wound and get through to granulation tissue, and of course, watch that wound proliferate. And of course, the other thing, and Joy mentioned it already, is that when you have biofilm, you're likely to have increased exudate levels. And this patient had treatment with a silver product, but he also had some negative pressure at this point as well to try and push that wound on. And so what we've got is a static wound. It was cleansed and debrided. We used then a topical antimicrobial in between dressing changes, and we continually debrided until that wound healed, if you like. So, so the important thing about using a topical antimicrobial after we've done that debridement is that you prevent biofilm reformation, but you also help to kill off any planktonic bacteria, those single bacteria that are lying in the wound as well. So that's the important part of using the antimicrobial. It's about using them at the right time. And the other thing that we would always maintain is that using an antimicrobial shouldn't be forever. You should use your antimicrobial when it's needed most. And I would say use it for 2 weeks and then reassess the wound. If you still need the antimicrobial, then keep using it. But after a couple of weeks, you should keep reviewing what you're doing, and you can maybe step down to a different type of dressing, but obviously, again, one that supports the wound healing process. And very briefly, the EXUFibre AG+, which is the new gelling fibre product that we have here at Mölnlycke. We've been doing some work with that with respect to its antimicrobial action, and we did a live study, a live animal study, and we showed that we could reduce significantly the biofilm bacteria in those animal studies, both with like a 93% and a 99.9% reduction, or log4 reduction in biofilm bacteria over 3 and 7 days. So really importantly, we're showing that the product is actually really good at helping to reduce the biofilm itself and prevent biofilm reformation. So just to recap, it's a fairly easy process, and it's one of these things that once you're doing it regularly, it just becomes second nature. So we need to cleanse and debride those wounds that are static. And when you do that, you're challenging the wound. You're actually maybe creating a little bit of an inflammatory response as well. And then you've got your 24-hour window to use your antimicrobial products. And that is when they're most successful. So at this point, obviously, you'd be using your silver products such as EXUFibre AG+ at that time. And then again, we reassess. So as I say, don't be using it for months on end. Use it for a few weeks and check that the wound's progressing. And if the wound's progressing normally, then again, you can change the product away from an antimicrobial. But initially, you need to challenge the biofilm by debridement and using an antimicrobial. Thank you. I'll hand back to Joy now.
Okay. Thank you, John. That's really interesting. I always find biofilms interesting anyway, and I know some of you might want to switch off at that point, but I think it's just so important that we do address that challenge to you as a clinician and to the patients about biofilm, not just formation but reformation and that window of opportunity. And so we've addressed the clinical challenge with EXUDATE, and John's addressed it regarding biofilm formation. What I want to talk about, though, is how those challenges look in real life. What does that mean to the patient and the clinicians? As you can see on your screen here, there's a picture of a patient who has got high, not very large wound, you might look and think, you know, but producing high levels of EXUDATE. You can see that those high levels of EXUDATE are coming in contact with the peri-wound skin and the wound bed itself. It's causing that damage, that erosion to that peri-wound skin, causing that erythema, that heat and the redness. And you can imagine that was extremely painful and uncomfortable for the patient, not just on dressing change, but also following dressing change. Due to the poor management of that EXUDATE, there was increased dressing changes. So again, that discomfort for the patient, but also the impact on their quality of life. You know, patients may be at work, patients may be at school or university, and they're having to attend to have more frequent dressing changes. Again, that debilitating impact on the patient's quality of life. Many of my patients say to me that their biggest concern when we're discussing EXUDATE and fluid coming from the wound is their fear of leakage or strike through on the dressing, because that will lead to embarrassment. You imagine yourself if you're with friends and you have a wound and it's showing leakage, how embarrassed you would feel and your loss of dignity. These patients, or you yourself, if you have a wound, may then be reluctant to socialise. Even if you're housebound, be reluctant to invite people into your house because of that fear of leaking and embarrassment. But also, as we know, with exuding wounds, can be associated with malodour and smell. So again, that's embarrassing for the patients too. These are my patients' words. This is what patients have said to me about their challenges to their quality of life when it came to high levels of exudate or biofilms or infections. Here you can see the smell is the worst thing. When it's really bad, I cannot go to work. And we often associate wounds with the older population, but actually it's not. It's all age ranges, from children through to the elderly. And you can imagine if this was you or your sister or your brother or your family member with licking wounds and needed to work, you know, loss of income, the impact on their life. Here, I won't go out to meet friends in case my wound dressing leaks. And I have had patients who have attended clinics, or I've seen them in their home, and they've actually said that they have been turned away from restaurants and cafes and bars because they've had a dressing that looked soiled. And you can imagine how embarrassed and loss of dignity they felt. One of my patients for 14 months, I've suffered with wet legs. I feel so depressed. And I think one area that we really need to focus on is, you know, anxiety and stress that these clinical challenges face, that the patients face. I frequently have referred many of my patients for counselling and support due to anxiety and sometimes clinical depression as well. And we mustn't forget about that impact on the patients. But what are those challenges to you as a clinician and to the healthcare providers you work for? Huge financial implications. We know that. We know wound care is growing. We know the burden of wound care for all of the work that's been done over the last few years. So it's a growing concern. But there are huge implications if the wounds, you know, if we're not managing those clinical challenges, then it's going to mean more dressing changes. It's going to mean more use of resources. It's going to be more use of your time. And the highest cost is your time. And we're going to have increased use of resources. I've seen myself that funding to certain areas, particularly community nursing, has decreased over the last few years, yet their workload hasn't. So they're still having to operate at high levels under high areas of stress. Same with wards. I understand that on acute wards also. We're seeing an increase in the number of patients with chronic wounds, and that is envisaged that internationally that's going to increase over the next 50 years as well. We, of course, know about COVID-19 pandemic clinical challenges too, and I'm sure you don't need me to emphasise those, but you are all under enormous stress, anxiety, and so are the patients. And patients are being reluctant to seek medical advice, to seek advice from yourselves because of fear of allowing clinicians into their home or attending for any appointments because of their risk. So again, there's massive challenges on yourself. I spoke to a consultant recently who said he has seen so many increased referrals for infected wounds and diabetic foot ulceration deterioration due to the patient's fear of seeking medical advice. And I'm sure you've seen that yourself in practice. And I think in line with all of these clinical challenges is the availability and access to keeping ourselves up to date and evidence-based, being aware of new innovation. It is difficult, I understand that. It's really difficult to keep abreast. And, you know, I'm talking to the converted this evening because you're listening to us and updating your education and your knowledge and going to be updating your skills and practice, and I commend you for that. But we have to make sure that these platforms are available and transferable to all areas. So when you watch it, you share it with your colleagues, etc. What I've noticed the clinical challenges are, though, for wounds with those complex challenges is that we have an increase in referral to other specialists. So to tissue viability specialists, vascular nurse specialists, leg ulcer clinics, wound care clinics, you know, other consultants. So there is an increase there for healthcare providers due to the increase in referrals also. So how can we address those clinical challenges? We're talking about wound exudate, and I totally understand it does begin with that wound exudate assessment. You have to know what it is you're looking at when you're examining wound exudate. Of course, this does not go without saying that the patient's assessment comes first. We need to address if there's any underlying comorbidities or wound etiologies that are contributing to that increase in exudate. And I'll talk a little bit more about that on the next slide. But when we're looking at exudate assessment, we equally, as a clinician, I need to be aware of what phase of wound healing is that wound in at present. How old is that wound? If it's an acute wound, is it in the inflammatory phase? So will I see more exudate being produced? What is the wound bed tissue like? If it's 100% granulation and it's proliferating and moving on along the healing continuum, it might produce a little bit more exudate at that point. However, if the wound bed has got devitalized, sloughy tissue with a lot of microorganisms, then again, it would be indicating to me that exudate levels may increase. So just by knowing, the duration of the wound, the stages of wound healing, and what tissue type you're looking at can influence your exudate assessment and management. As John has said, we cannot visually see biofilms in a wound. We can see them definitely on the plaque of your teeth and gums. So, but with all of the research and evidence that's been undertaken into biofilms, has concluded that the vast majority of chronic wounds will contain a biofilm. So for me, if the wound is a chronic etiology, I already want to implement a biofilm wound care pathway. When I'm looking at the volume of exudate, it is subjective. There is no international consensus to measure wound volume. But what you can be doing is examining the soil dressing, the weight of the dressing, how long has that dressing been in situ? Okay, that can give you an indicator of the volume, okay? But look at the colour. Healthy exudate should be a clear, amber, thin consistency. The darker the exudate becomes, so let's say that dark brown exudate or that green Pseudomonas type exudate, and the thicker the exudate is, and I'm sure you've seen that thick viscosity exudate, it's an indicator that there's increased amount of microorganisms within that wound bed. So again, it's telling you as a clinician, we need to ensure really robust cleansing and debridement, and we need to really look at reducing the amount of microorganisms in the wound. And smell. Okay, the smell of a wound exudate can also help you to assess if there's infection locally, if the exudate is changing, and I'm sure all of you have, unfortunately, smelt wounds that are malodorous. And you can imagine if it's distressing for you, how distressing is that for the patient and their family? So examine that soil dressing. Look at the peri-wound skin condition. Is there any skin damage there? Is there any erythema or maceration, that waterlogging white effect? If so, that exudate is being left in contact with the skin and is causing changes now. And of course, what is the impact to your patient? Involve your patient and the carers to know what is the impact on their quality of life, because you as a clinician can start to address that impact then. So if the patient, for example, says, I'm really worried about going out, I haven't been out for the last, I've had a patient recently for 12 weeks because I'm scared. I'm scared it's going to leak, and I just don't want the hassle of worrying about that. So, work with the patient to reassure them, to improve their experience by implementing effective products that are going to absorb that exudate, that are going to lock it and give them the confidence to start now socially becoming more active and giving them confidence in their treatment. So the other key principles that I've addressed, not just about exudate management, but about addressing those clinical complex challenges, are optimising the patient's underlying patient comorbidities and etiologies. Then, as John has talked about, that effective and consistent wound bed preparation, debridement, cleansing, and biofilm management. And of course, certainly when we're talking about exudate management and biofilm prevention, that appropriate wound dressing selection and retention of exudate. So underlying comorbidities, addressing that with your patients. Some of your patients, I'm sure, I've done a recent study that showed that out of 34 patients that we were delivering care to with a wound, all 34 patients had more than 2 comorbidities. And so, you know, we are also dealing with factors that may hinder the wound healing process, such as cardiac disease, renal failure, hypertension, all factors that may hinder the wound healing process. But what I'm not asking you to then solve the patient's cardiac disease or diabetes, what I'm asking you to do is work with the wider MDT team. So if I have a patient who has a respiratory disorder, I'm struggling to heal their wound, I will work with it, and their respiratory condition is not very well controlled, then of course I'll work with the specialists, the respiratory nurse specialists, the consultants. I want to optimise that patient's well-being in order to help them, but also to help and facilitate wound healing. If there's chronic edema or lymphedema, dependent edema or venous disease, we need to address the underlying etiology. So we need to look at suitable lymphedema therapies and compression therapies, and ensuring that, because that could be the main factor of how you manage that exudate, because that can be the contributing factor. As John, I won't go in too much detail on this slide, but you can see that wound bed before debridement, that devitalized tissue that's going to cause a barrier to any new proliferation of cells. It's going to delay granulation and epidermal resurfacing and wound contracture. We'll get increased bacterial burden because of the devitalized tissue, increased risk of infection, and an acute wound can very easily become a chronic wound. We need to disrupt that. We need to debride that tissue. We need to break down that matrix of the biofilms, and that will facilitate that healing of the wound. So again, use the window of opportunity. Every time you see a patient, that's the time you reassess your patient. You reassess the wound. You reassess and reintroduce that disruption, that debriding, that cleansing every time. And when it comes to dressing selection, I think when I've talked with clinicians and my colleagues, they actually say this, they find this really difficult to know what dressing to use. And I always, even now, when I'm thinking about what dressing to use, I ask myself several questions. What is it I want to achieve? When I'm looking at the patient's wound and exudate levels and wound bed, what is it I want to achieve? So that picture you saw previously with the devitalized tissue, I want to achieve the removal of that devitalized tissue, don't I? I want to promote granulation, but I equally want to absorb exudate and prevent any exudate-associated skin damage. So what do I want the product to do then? So I need to know how my products work. I need to know their mode of action. And I know, unfortunately, sometimes we use products due to familiarity or because it's what, you know, we've been advised to use. But just each time you're with your patient, use that opportunity to say, what do I want the product to do? I want it to promote autolysis and removal of the slough. I want it to contour to the wound bed space. I want it to reduce the formation of biofilms, and I want it to absorb that exudate and lock it away. What dressings do I have that will be appropriate for that wound bed, and implement them? So, as I've just said, the dressings are our mainstay, the primary and secondary, if you use both. They are our mainstay. They have to be able to manage not just volume of exudate, but let's remember that viscosity, that thick viscosity exudate. We want it to promote the moist wound healing, but not a dry wound healing or a saturated wound healing, but without damaging the peri-wound skin. Certainly for me, most importantly, is improve our patient experience and quality of life. Be comfortable and atraumatic, not just on dressing change, but also during wear time. And I think more importantly now, in today's overstretched healthcare and your clinical time, facilitate the change of dressing frequency and extend that wear time. You know, I certainly don't want to disturb a wound, the wound healing process, if I don't have to, because undisturbed wound healing means improved wound outcomes. Again, what I've noticed more so when we're looking at supported self-care for our patients and carers, and also following training a lot of redeployed staff into community nursing teams that have had no exposure to wound management, in training them into wound management. We need clear clinical pathways that are, and products that are easy to apply, so that staff are confident and so are the patients, and of course be available. Dressings themselves can manage that exudate by absorption. I'm sure you're aware of that, or by evaporation or both. Some absorb the exudate and lock it within the dead space of the dressings. Some may gel, so you apply a dressing and on contact with the exudate, it forms a gel within the wound bed and absorbs the exudate also. But the one thing I will say about, if we're talking about gelling dressings and primary dressings per se, please ensure your primary dressing can reach every contour of that wound. We often look at a wound and think it's flat. It's not flat. There'll be lots of contours and little areas and pockets. And really is important that your primary dressing can mould and be conformable into those contours. If there's wound depth, of course, we need to be able to layer the wound dressing into that cavity, and it's important your dressing is effective for that and can be used for that reason. So if there's undermined edges to a wound, we need to ensure the dressing is in that undermined edges. The reason for that is we want to lock we want to fill dead space. We don't want pooling. And what I mean by that is if there was a layer between your wound dressing and the wound bed and what we call a space, we call that dead space. And if there was dead space, what would happen? You'd have an increased amount of exudate pooling there. Increased number of microorganisms would now start to be produced. And from that, then there would be challenges there of increased infection and increased problems for the patient. So we want it to contour and be able to do that. So secondary dressings, again, in terms of that, will also need to be able to manage the type and volume of exudate and be able to transfer that exudate effectively from the wound bed to a secondary dressing, again, preventing any further problems. So in summary, we know exudate is vital for effective wound healing. Okay, it's not the bad, it's the good. It's essential for wound healing. There are various clinical complications with all wounds, and effective wound bed preparation, prevention of infection and biofilm formation, and exudate management, everything that John and I have talked to you about this evening. If it's effective, it'll have clear and positive outcomes for you as a clinician, but for the healthcare providers, but most importantly for your patients. And make sure that assessment and that wound management is ongoing. It's every opportunity when you meet your patients, and it's individualised and patient-centred around your patient's needs as well. And as you are doing this evening, maintaining your knowledge and skills and being aware of appropriate dressings for appropriate wounds. So it's the right dressings for the right patient for the right wound, and being aware of new innovations as well. And what I'd like to ask you to do is, very frequently, I learn myself a lot by going online and learning and live events like this. Tomorrow, what will it mean to you? Hopefully tonight, after you finish this presentation, you'll relax. You may be relaxing now with a glass of wine in your hand, I hope you are. But you'll reflect. Tomorrow you'll reflect on what you've learned today. And it's important that you do that and ask yourself, what I learned last night, what does it mean in practice for me today? I want you to choose a patient you're caring for, just one patient, and implement this learning into that just one patient with a wound, okay? And follow that patient's journey for 2 weeks and record the outcomes, record the size, the wound bed, every opportunity, every window. When you see that patient, you and your colleagues record the patient's quality of life, the impact on those. And look at the positive outcomes when you've implemented what you've learned. And then share it. Share it obviously with your colleagues and your experience with your colleagues, but also share it with your other patients. And thank you for listening.
Thank you very much, Joy. And thank you, John, as well. Really, really interesting sessions. We've had hundreds and hundreds of people watching tonight. So a big audience, lots of comments, lots of questions coming in. So if you have submitted a question, we'll try and get as many of them answered as possible now in the live Q&A. Keep sending in your questions, though. If we don't get through all of them, we will try and answer them in the next couple of days. But we'll move straight on to our live Q&A now. And just moving on to our first question. This one is for you, John, from Jenny McDonald. Hi, Jenny. John, why do you think mechanical debridement does not feature routinely in patients' wound treatment plans?
I think it's just it's a bit of history, to be honest. I think that we if we go back a few years ago, debridement became something that maybe the specialist nurse was doing, and then it didn't seem to be cascading down to the nurses who were sometimes delivering the care, who were actually managing the patients. And I think it's a really important part. It's an important step in wound care. I think we should be using it more, and I think that it would make a big difference to outcomes if we encouraged mechanical debridement, because the new mechanical debridement agents that are there, the debridement pads and things, are really safe to use, and they're simple to use, and actually for me it really helps disrupt biofilm and can push that wound to the next stage. So I think it's a bit of history, I think, with debridement. There's a bit of mystique around it, and I think it's definitely something that we should encourage our nurses to do more of, because I think it's a vital step in wound healing, definitely. What about you, Joy? What do you think of that?
Yeah, no, I totally agree. And I want to first of all apologise to the audience, because I think part of my presentation was almost done in the dark. It's just gone dark very quickly here, and I do apologise, I didn't put a light on. So hopefully you did still see me, but really, to be honest, you don't need to see me, you just need to see the slides. So apologies for that. So a bit of a panic over. Debridement, yeah, definitely. And I think sometimes we don't always get that right. And I think if the wound bed isn't prepared, it doesn't matter what you place on the wound, of course it does, but the products are going to be so ineffective because you've not stimulated that wound, you've not prepared that wound bed. And I liked what you said, John. That stimulation also stimulates that inflammatory response. It kickstarts that wound healing process again, almost in that small time frame. And this is what we're talking about tonight. We're talking about the importance of that time frame and getting it right. And good cleansing and debridement, you know, even if you've got a really nice, healthy granulating wound, you can continue that good cleansing. You are, you know, one, preventing biofilm formation and microorganisms and other factors. You're removing any devitalized residue off the wound dressing, but equally you are almost giving that window of opportunity to cascade the wound healing process as well. So yeah, I love debridement. I think a lot of nurses as well, or clinicians, sorry, not just nurses, feel that they don't debride wounds, but actually there's lots of opportunities to debride wounds, like you mentioned, John, with the debridement pads, etc. We can all be debriding wounds, all skill mix as well. Doesn't have to be an RGN.
Brilliant. Yeah, and so moving on to question 2. This one is, with long-standing wounds, do we expect the presence of biofilm?
John, you, me?
Okay, yeah. I mean, there's a lot of different studies out there, but they reckon anywhere between 78 and 99% of all long-standing wounds will have biofilm in them at some point. It'll be there. It might not always be. As I say, it's not something you can see. It's not obvious, but part of the whole reason it's long-standing is likely to be that biofilm is playing a part there. So it can also be underlying conditions, but I would say definitely biofilm is going to be in most chronic wounds these days, and unless you do what we've been saying tonight, unless you challenge that wound, then that biofilm will remain, and your wound will stay open. And again,
and I think,
for that too.
Yeah, I think, John, you're right. I mean, there's lots of studies, and you're right, ranging anything between 70 and 90+% of all chronic wounds, and how they've identified that is through microscopy, where they've, you know, obviously with devices where they can look and have identified those communities, those biofilms, and proven that they do exist within that wound bed. So it's just difficult for you as a clinician to visualize that, but if you're aware of the evidence, you know, so that evidence is saying that those majority of those wounds, long-standing wounds, because those long-standing wounds are chronic wounds, will have a biofilm present. And biofilms can exist across a wound. They don't necessarily have to cover the whole of the wound. There may be different biofilm communities in different parts of the wound as well. That's why it's really important to debride and cleanse all of the wound and the peri-wound skin as well.
Brilliant, thank you both. Question number 3 is, can you change a dressing too often? We start with you, maybe, Joy.
Yeah, shall I answer that one? Yeah, I think you can. because, like I say, about disrupting the wound healing process, we need, again, I know I keep talking about windows of opportunity, I'll have to change, you know, but the wound needs time. The wound and the patient's body, because don't forget, it's the patient's body that heals the wounds. We facilitate it with a good cleansing, good wound products. The patient's body's helping as well. If we disrupt it too often, so let's say we do a daily dressing that doesn't warrant a daily dressing because, you know, EXUDATE levels are managed, it's, you know, the patient's comfortable, then we're disrupting that cell proliferation across the wound bed. And really, and evidence has shown, really strong evidence has shown that the less we disturb a wound, the more effective outcomes for wound healing. But of course, we have to disturb wounds when we are required to cleanse them and change them accordingly. So hopefully that answers your question.
Perfect. Thank you very much. Question number 4 is, could you please advise on overgranulation wound management?
Oh, I'd like to know who asked that one. I might look later.
There's no name alongside this one.
Oh, that's a cop-out then. Yeah, I mean, I very, very frequently get asked about overgranulation on a wound bed. Now, what I will say is I don't worry too much about natural overgranulation. If I see overgranulation in a wound bed, I'm going to talk as if I am just seeing my patient now. I'll ask, first of all, is it true overgranulation? So I want to know how the wound started, what the etiology is, and I'm just ruling out there's no suspicious tissue there. So that's my first part of my assessment. If it's overgranulation, which I feel is overgranular tissue, which is, you know, we've just produced too much granulation tissue too quickly in the wound bed, and there are pathways that can support you with that. So there is talk to use debridement and use a antimicrobial dressing for a short period. So we normally say the 2-week period to try and destroy some of those granular cells. So actually, we're trying to reverse what we've been trying to promote. We're trying to destroy those new cells. Sometimes it's advised to put a little bit of pressure on that area. So let's say a foam dressing over the top. Licensed products for overgranulation. There is a specialist tape impregnated with a steroid that is licensed for use on overgranulated wounds. So that would be my next go-to if the antimicrobial and other process hadn't worked. And then following that, if I still had problems, then I would be discussing that overgranulation tissue maybe with a dermatologist, because there are certain steroid creams and ointments that are used off license but under the guidance of a specialist who could use those. So hopefully that's answered that. I mean, I know many years ago we used to use a lot of silver nitrate sticks. I don't tend to use that, but the principle there is using the silver to destroy. But if you use the silver dressing, you could use that. And they can be very painful using the silver nitrate as well. So I just think that's outdated practice. That's my opinion. So hopefully I've answered that one.
Yeah, brilliant. And this one, question number 5, maybe for you, John, this one. Would it be more appropriate to use a ribbon dressing or sheet dressing when packing a wound?
Yeah, I would definitely recommend using a ribbon dressing. I think it goes back to what Joyce said. When you're managing a wound that's full of contours and maybe undermining and things, it's much easier to get a ribbon dressing into a cavity, for example, and you can kind of ensure a bit more contact with those areas of undermining and the wound bed, etc. And so with a flat dressing, you tend to find that it will contour well enough, but you can't really get to the undermined areas. And of course, one of the things you want is a dressing that comes out in one piece as well, which is quite important. So from that perspective, I would say, and the other thing we always say is, like, don't overpack the wound. Don't pack it tightly. You should put your dressings in loosely so that they get, because gelling fibres will absorb and they'll swell. So it's important to make sure that you don't pack too tightly, because it just really impacts on the wound itself, and you shouldn't really be trying to force things into a wound that should be going in gently and layering it in. But definitely ribbon makes it much easier just to get into all the contours that like Joy was mentioning.
Yeah. And I think to add to that, John, sometimes I have in practice on the very large God forbid, the very large pressure ulcers that I have seen, some of the larger wounds. Sometimes I always like to use the ribbon normally, but if I have a very large wound, then sometimes I may use the sheets as well and shape those to fit in the undermined edges of the wound, etc. So, but I think first choice would be a ribbon, but it is dependent on the size of the wound and like John said, just knowing that dressing can be removed easily in one piece, and you know how many pieces you've used, and I love John's analogy that we lay dressings into a wound, we don't pack them, because sometimes packing we overpack.
Perfect. Thank you very much. Okay, question 6. This one for you, Joy. How do you know when you've removed the biofilm if you can't see them?
Hopefully, if you know, what you should see clinically is the wounds start to move on along the healing continuum. You will see a reduction in exudate levels, and the wound bed will start to appear with less slough and less devitalized tissue. You will see the positive outcomes of that good biofilm management. So clinically, that's what you should be seeing. Certainly the wound moving along the healing continuum, but the first things you'll probably see is a reduction in exudate and a reduction in the amount of sloppy devitalized tissue on the wound bed. And then in turn, the wound should start to move along that healing continuum.
Thanks. Anything to add, John?
No, just the same as Joy, because you can't see biofilm, but we know it's there. So it's all about looking at that wound, and it's about the reassessment we talked about. You know, Joy mentioned that a few times. I mentioned that it's going back and checking where the wound progress. You know, and one of the best signs of wound progress is the wound area reduction. You know, you should be seeing a difference in the wound size. And also, when I showed you a couple of those wounds earlier today, and Joy had a few in her slides as well, that, you know, wounds look a different colour when the biofilm's there. You know, they change colour, they kind of look a bit dull, they look a bit lifeless almost. And Joy mentioned that again, was that when you debride, especially if you think about mechanical debridement, you tend to wake that wound up. You kind of see a little bit of an inflammatory response, but it's controlled. It's not a negative inflammatory response, and it drives the healing process again. So that's where you're really trying to do it, and you'll know that's happening with a wound. You know, you'll know that wound is progressing, and one of the key signs for me is the colour of the wound, but also the reduction in wound area over time, and that gives you a really good indication that the wound is going the right way.
Sure. Thank you very much. Question number 7. What do you do with edematous or weepy legs with blisters?
Oh, well, I think John's going to leave that one to me, aren't you, John? I think, to be honest, it's very difficult because that's a very broad, you know. So first of all, if that was a patient I'm meeting for the first time, I'd want to know, obviously, their underlying, their health, you know, any underlying diseases, what's causing their limb to become edematous and blistering. Before I even start thinking about how I'm going to manage the wounds or the blisters, I would want to know what is contributing to that. Now, it could be underlying health disorder, you know, it could be heart failure, it could be respiratory disease. If that's the case, I need to be talking to the patient, of course, to know how that's being managed, the patient's GP or specialist team involved, such as the respiratory nurse. If it's due to underlying etiologies such as lymphedema, then I need to address the lymphedema with lymphedema management. Okay, so compression therapies and other therapies. But again, I would involve the lymphedema specialist. If it's due to dependency, the patient may have become immobile. And I will say during COVID-19, I have seen an increase in referrals for patients with edematous weeping limbs. And I feel it's because that reduced mobility now, they're either not leaving the home when they could because of their fear and they're isolating, or, you know, where family members would have taken them out and encouraged them to walk, they no longer are visiting because of the risk of COVID. So we are seeing an increase in that. So if it's dependency and due to the patient moving, it's that education with the patients about moving around their own home. You've got to manage that edema. And so following assessment of the patient and the limb and vascular assessment, you know, Dopplers and ABPIs, I would be looking at compression therapy if possible, and really just really good, you know, wound assessment. But if you control the edema and the fluid, the blisters, the wounds will heal really quite quickly. So addressing the underlying first.
Thanks, Joy. So we've got 2 more questions. Question number 8 is, what drives bacteria to produce a biofilm? John, take it away.
Okay, I mean, basically, biofilm bacteria form when they're attached to a surface, and they start, as I said, communicating with other bacteria that are on that surface as well, and they're driven to that. It's like a genetic thing essentially, and it's designed to protect the bacteria. So essentially, they're aware that maybe they're not going to colonize that surface. There's not enough bacteria there to do that. And what we find is that the bacteria themselves start to communicate. And like I said earlier, it can be with other different types of bacteria. So sometimes biofilm are polymicrobial, and we can have different actual strains of bacteria present. And what they're doing is, what drives them is that they're not in a position to divide extensively and overtake that wound, but what they are in a position to do is communicate and then form this extracellular matrix, this glycosylated, starchy, sugary matrix that protects them. And it's almost basically, then they can live happily under there. They're provided with nutrients and stuff, and what they're doing is almost like overtaking that wound slowly as a biofilm, and not infecting, if you like. So it's very different activity from bacteria that infect a wound, and so it's quite interesting, but also extremely, it's not great for patients either. Of course, you know, some biofilms are really hard to break down. Pseudomonas biofilm is really hard, difficult biofilm to break down, and so they can be quite rigid, if you like. And so yeah, biofilm it's a way that bacteria are found, if you like. It's almost it's like been a clever way to avoid the impact of antimicrobials. And the first patients that we used, or we found biofilm in, were among obviously with dental work, but also in patients with cystic fibrosis, where the Pseudomonas bacteria is creating biofilm in the lungs, and it was really hard to shift, especially with just antibiotics. So, so it's a really clever way for bacteria to evolve, if you like. So,
thanks. Go on, Joy.
No, I was just going to say as well, adding to John, you know, about using those antimicrobials. And we have to break down, I call it the shell, we have to break down that shell so that the antimicrobials, the patient's own antibodies, if the patient's on antibiotics, hopefully not, because we don't want to overuse them, but they then have a target, they have an opportunity to attack the microorganisms. So if we don't break down that casein, the bacterial, as John said, are protected, but we've then got that opportunity. Sometimes we'll use antiseptics or surfactants, and how they work is they stop cells adhering to the surface as well. So we might use that as well as an antimicrobial, but it's preventing that reattachment really, and giving you the opportunity to attack the microbes. And the microbes in a biofilm are very inactive. We call them, they've gone to sleep, as John said. But when you disrupt the cell, they become very active, and that means then the antimicrobials and antibodies can do the job, because they only work on active bacteria rather than inactive bacteria. So hope that helps a little as well.
Thank you both for those. And so this is our final question. In the new wound care world we are steering through, what and where are the best ways to access relevant education?
Do you want me to start on that? Yeah, I mean,
yeah.
I think education's for everybody, isn't it? I always need to keep up to date. I just think every day there's something, particularly in the wound care arena, there's something new, isn't there? I think for you as clinicians, you don't just need to know about wound care. Gosh, you've got to be experts in so many fields, and I commend you for that. So these sorts of platforms, it doesn't have to be just wound care platforms, it can be community nursing platforms, acute nursing, surgical nursing, diabetic foot, not just nursing, podiatry forums, diabetic foot forums, but it's got to be online now. I mean, I used to do a lot of lecturing face-to-face at conferences, but at the moment we're not going to be able to, so very much online. I'm a big believer that education should be free. and I think it should be available to everybody, and I think it should be for all skill mixes. I believe we educate all of our team members in all aspects of wound care, but also other aspects. So, you know, so there's companies who have some very good e-learning modules and a lot of those are accredited as well. So if you're doing your revalidation, things like that, really good for your revalidation points and personal development. That, you know, obviously wound care people do hundreds of platforms, lots of platforms where you can learn. You can learn individually on your own through e-learning, or you can share it via groups like this. So I just encourage you to sign up to lots and lots of different platforms. And I think the good way of learning is discussing with your other colleagues, and hopefully some of you tonight have been sending messages to each other, because I do that when I'm watching them, and I'll say, oh, that's a good idea. Can I have that example of that wound care pathway for a biofilm? And share it, guys. Don't reinvent the wheel. Work together. We need to work together more than now than ever. And ask your patients as well. Let your patients go onto platforms. Look at the National Wound Care Strategy platforms, a valuable resource now for you as clinicians, but for your patients as well. The Legs Matter campaign, brilliant vocal platform for your patients. And you started me, you know, I can talk for England, but yeah. And if you need any more information about these platforms, I know wound care people, Monica and myself are happy to share them with you later.
Yeah, absolutely. And as Joy said, you know, on our websites, if you're not already subscribed, woundcare-today.com. There's e-learning modules, there's a digital journal on there, so you can subscribe to all of those, but also make sure you're following our Facebook page so that you don't miss future Facebook Lives as well, because we're constantly bringing up more and more Facebook Lives, so keep an eye out for those as well.
Yeah. I'll just get a little plug in for the Monica Advantage website as well, which is on the Monica website. But I mean, the reason I'm recommending it is not because it's not full of product information. It's actually full of key clinicians like Joy and other clinicians from across the globe presenting on topical wound matters. It's not on product information or anything like that. It's purely about education sort of thing. Because I mean, companies know, we know what's important is that if we get nurses doing wound care right, and you know, if they're using the products well, then they will use our products, but we want them to practice as well as they can. You know, we want education levels to be up as high as they can be, sort of thing, to promote good practice. And so that's what the Advantage website's all about. It's professional education. So, and I do think a lot of the companies do that well, and I think that's important, that companies do provide a lot of education. And we're very careful not to be talking purely on product all the time. But I do agree with Joy, there's a lot of places to get information nowadays. But it's really more important than ever now, because we're not going to conferences, we're not going to sit in congress halls for another 6 months, I would say. So it's really important to keep up to date if we can.
Yeah. For sure. Well, thank you both very much for that. Brilliant sessions, some brilliant comments and questions coming in. So we really appreciate all of your questions. If we haven't got through to your question, then we will try and answer it in the next couple of days. Thank you very much, Joy. John's going to talk to you in a second about Molnika's 2-week challenge. So I'll pass over to him in a second, but I just want to thank Molnika and Joy and John and yourselves quickly. And I'll be back in a second after John.
I just want to round off just to say thanks to all of you. I've been watching the feed coming in on our Facebook Live. Some brilliant questions, some really good engagement with the audience. It's been amazing. Thanks to Wound Care Today for staging this. Thanks to Mo Productions. But just importantly, I talked earlier about EXUFiber AG and its management of biofilm bacteria and prevention of biofilm reformation. We've been talking about the importance of EXUDATE management. So we have 2 new products at Molnika, EXUFiber and EXUFiber AG Plus, which is a new technology. It's PVA technology used in a gelling fibre product, which we feel can really benefit the wound in terms of better EXUDATE management, better prevention of biofilm reformation, and also that all-important debridement piece in between your physical debridement. So what we're asking you to do is to take the 2-week challenge. We want you to tell us what you think of the product. So after this slide, there'll be a link to a website. You can sign up and we can send you some samples if you want to do a clinical evaluation. And one of the clinical team will follow up with you to see what you think of the product, because it's okay me talking about it, but I want you to give me your feedback and tell me what you think of the products themselves, because they are new. We've not really used them in this way before. They're newly launched, so I think it's really useful for us to get your feedback. But the early indications are that they're really changing the way we manage these heavily treating wounds and these wounds that have biofilm on them. So it'd be good to hear from you. So I'll move on to that. I think I'll move on to that slide now, Sam. And as I say, you can click through the link and that should take you to the right page to sign up for the 2-week challenge. So good luck.
Perfect. Thank you, John. And those links should be in the comments section as well. So you should be able to click those directly from there. You can also watch this video back at any time on our Facebook page. It will also be available on our website, which is woundcare-today.com. In the Facebook section of that website, you can watch this back in a day or so. You'll also be able to download the slides from there as well. And the certificate link should also be on your screen now. That will also go into the comments section. So download your CPD certificate for your revalidation, and you can add that into your folder as well. Don't forget to like the Wound Care Today Facebook page. You'll hear all about our next events on there as well, and you won't miss any of those. Thank you very much for joining us. Enjoy the rest of your evening, and we will see you all for the next one very soon. Thank you very much.
Thanks, guys. Thanks, Joy.
Thank you.